Welcome. Let's talk about management of critically ill patient in the emergency department or in any other area, example in the intensive care unit or in the respiratory care unit. So the learning outcomes would be the importance of early recognition of a patient who is deteriorating. What are the causes that lead to cardiac arrest and how to recognize them in ABCDE approach. So there is a chain of survival in which are composed of 4 chains which are related to each other. The first one is early recognition of bad symptoms and calling for help. This is to prevent cardiac arrest. When a patient is having abnormal vital sign or having a chest pain or shortness of breath or loss of consciousness, then you have to recognize and do resuscitation as early as possible. This is to prevent cardiac arrest. But if cardiac arrest happen, you have to do CPR as early as possible to buy time and give defibrillation. This is to restart the heart. So if the patient have chance to survival, they will have return of spontaneous circulation. For patients who are having cardiac arrest, only 10 to 20% may survive, may return to spontaneous circulation. Others will die. That's why you have to do a post-resuscitation care to restore the quality of life. This is by doing ABCD approach. So the most important step is early recognition to prevent cardiac arrest, to prevent death, to prevent admissions to ICU, to prevent inappropriate resuscitation attempts. Most cardiac arrests are predictable. In about 50 to 80% of patients were having deterioration before cardiac arrest happening. An example is a patient having this chart with follow-up, have increasing respiratory rate, decreasing oxygen concentration, then decreasing blood pressure, and also increasing the heart rate. So this patient obviously is deteriorating. Most of the causes were due to hypoxia and hypotension. In other words, if you treat hypoxia and hypotension, you can prevent death or prevent cardiac arrest in most of these patients. Delays in referral to higher level of care is also a problem. For example, a patient is having abdominal trauma and having shock. So you are suspecting intra-abdominal bleeding. It's true that you are giving oxygen and fluid and blood prosthesis, but at the same time you have to call a surgeon because unless the patient going to surgery, they may die. That's why you have to call the surgeon early. Again, we have a system called early warning scoring system. This is in developed countries, especially in UK. They are doing vital signs, and the vital signs have a normal range. Any deviation from that normal range, the patient will get a score. For example, if a patient having a pulse rate of 100 and a blood pressure for example of less than 90, and for example a heart rate, for example if the patient is having a respiratory rate of 21, so he will get 1, 2, 3 and 3 equal to 6. So he will have a scoring of 6. The higher the score, it means the patient is more critical. The lower the score, the patient is more stable. For example, if a patient is having a score of 3, just the nurse in charge doing follow-up. But if a scoring system of 9, the patient should be seen within 15 minutes and should be discussed with the ICU team in order to admit, because the patient is very critically ill and needs admission. Again, for follow-up, a patient with scoring system of higher needs minimal observation time of at least 13 to 15 minutes. I mean, you have to frequently re-evaluate the patient, while a patient of scoring 6 needs follow-up observation every 4 hours. So the ABCD approach for critically ill patient composed of ABCD: airway, breathing, circulation, disability, exposure. We will come through that one by one, But there are principles, underlying principles for each of these. You have to completely do initial assessment. I mean, initially you assess the patient in ABCD, then if there is any life-threatening problem, you have to treat it immediately, at once. So do not wait for the second one. For example, you are in the circulation, you found that the patient is shocked. Give fluid, give blood. Do not go to the D until you started resuscitation. Then once the ABCD completed, you have to do reassessment frequently. Why? Because to see the effects of your treatment and intervention, whether they have improved or not, and also call for help early. Also, personal safety, you have to wear gloves and gown and mask. The patient responsiveness is very important. As far as you are talking to the patient is talking, is responding, it means that airway is good and the breathing probably is good and the circulation is also good because there is good circulation to the brain. First impression may be gained by experience. Many doctors may see a patient from the far, they say this is MI. This patient seems to be heart failure. This patient seems to be asthma. So the first impression is important in order to gain an idea about the patient. Check the vital signs and the ABCD composite of vital sign. You have to know that when you see a patient who is critical or any patient in the emergency department, first you have to do a primary survey. The primary survey is ABCDE. When you do ABCDE, you have to treat any life-threatening problem that you found, and then you do secondary survey. The secondary survey composed of history, sample history, we will come to that later, and examination, focused examination. For example, the problem seems to be in the lung, you are examining the lung properly. Okay, let's come to the airway. What are the causes of airway depression, of airway obstruction? It might be due to CNS depression, for example, due to trauma, due to infection, due to intracranial lesion, due to some drugs which suppress CNS, example, benzodiazepine or opioid. Blood and vomit may obstruct the airway, foreign body, trauma to the airway, an infection, example, epiglottitis, or severe kissing tonsillitis, laryngospasm, bronchospasm, especially due to burns or due to allergic reactions. So how to recognize an airway obstruction? The first important thing is talking. The first step is talking to the patient. If he responds, it means that the airway is patent. If the patient is not responding, it means that the airway is not patent, or you are not sure about the patency, so you have to look, feel, listen. During look, feel, listening for the airway, you may see that the patient having difficulty in breathing, having choking, having shortness of breath, noisy breath like hoarseness of voice, stridor, wheezes, gurgling. You may see seesaw respiration, opposite. When you have inspiration, the chest draws instead of going out. The patient is using accessory muscles. So all this can tell you that there is an airway obstruction. Plus, you may do a pulse oximetry to the patient. How you treat the airway obstruction? First step, if the airway is obstructed, you have to do airway opening maneuvers, head tilt and chin lift. If the patient suspecting cervical injury, then don't do head tilt chin lift because you don't want to tilt the head. It may cause more neck injury. So just you do jaw thrust. I will show you videos later on. Then the next step, after opening the airway, you may do suction to the patient if the patient is having some secretions or blood. Then simple airway adjunct like oropharyngeal airway. If the patient not tolerating, example, the patient having gag reflexes or having vomiting, it means that oropharyngeal airway is not appropriate. So you withdraw the oropharyngeal airway, you put nasopharyngeal airway. Of course, nasopharyngeal airway may be contraindicated in patients with facial fractures, with suspected basal skull fracture. Then next step, if you are still not happy with the airway, you put advanced airway. Example, laryngeal mask airway. There is commercially available eye gel which looks like LMA. It is easier to apply. Tracheal tube. You put endotracheal tube to the patient. Okay, so if the patient still not improved, the anesthesia doctor may decide to do cricothyroidotomy, which is the last step. Don't forget to put oxygen to the patient. Oxygen should be applied first by face mask. The conventional face mask that you apply, you give 15 liters per minute, but it only gives a concentration of about 40 to 60% to the patients. If you apply face mask and the face mask connected to a reservoir bag, it will apply almost 100% oxygen to the patient. For some time the patient, you cannot put face mask or face mask with reservoir, then you may there is another type available called nasal cannula. The nasal cannula can provide about 30% of oxygenation to the patient, so the concentration is only 30%, and the maximum flow to nasal cannula should not be more than 6 liters. So maximum flow is 6 liters per minute. So this is about oxygenation. Let's show you some videos about head tilt, chin lift, oropharyngeal, nasopharyngeal.
In cases where you do not suspect a neck injury, lift the tongue away from the back of the throat and open the airway by using the head tilt, chin lift technique.
Position the patient by supporting the head and neck and placing the patient on his or her back. To open the airway, place one hand on the forehead and place the fingers of the other hand under the point of the chin. Push down.
Jaw thrust.
If you do suspect a neck injury and the patient is already positioned on his or her back, you can open the airway by using the jaw thrust technique. To properly perform this technique, place your fingers behind the angles of the patient's lower jaw and move the jaw upward. At the same time, use your thumbs to open the mouth slightly. The jaw thrust technique
Welcome to Airways Surgical Private Limited. Dell Airways. Measure the distance from angle of the jaw or earlobe to the nostril of the patient. Select the appropriate sized Dell Airways. It contains easy size identification with color coding. It contains reinforced pipe block. Lubricate it with water-soluble lubricant. Start to insert Dell into the mouth. Insert with curve facing the opposing direction. Continue inserting without pushing tongue posterior with following the airway.
Nasopharyngeal airways are produced in a variety of sizes to accommodate various patients. To select the correct size nasal airway, begin by visualizing the patient's nares and select a nasal airway with a diameter slightly smaller than the patient's largest nare. Once the diameter is determined, then measure the device from the tip of the patient's nose to the tip of the earlobe or angle of the jaw. The rubber washer or grommet can be slid back and forth on the device to ensure a proper fit. Lubricate the distal surface of the airway with water or a water-soluble lubricant. If inserting the nasal airway into the patient's right nair, insert so as to follow the normal anatomical curvature of the nasopharynx with the bevel toward the septum. Direct the nasal airway along the floor of the nose into the oropharynx. If inserting the nasal airway into the patient's left nair, it is necessary to invert the airway so the bevel of the airway remains along the septum. Once the nasal airway reaches the nasopharynx, rotate the airway 180 degrees to resume alignment with the normal anatomical curvature of the nasopharynx. Continue to insert.
Let's come to the breathing problems. The breathing problems could be due to decrease in the respiratory drive, example CNS depression, or decrease the effort of respiration due to muscle weakness, nerve damage, restrictive chest defect, pain from fractured rib, example flare chest. Lung disorders are the most common, especially due to asthma, COPD, infections, and sometimes rarely pneumonia, pneumothorax and hemothorax. Pulmonary embolism, when there is obstruction of the pulmonary artery by an embolus. Also ARDS, when there is bilateral lung involvement acutely due to infection, due to trauma or any other reason, and there is hypoxia. So these are the causes. How you recognize? By examination, by looking, by listening with stethoscope, and by feeling. So you look for the respiratory distress problems. You look if the patient using accessory muscle, any cyanosis, respiratory rate is very important, and if there is any chest deformity and conscious level. Conscious level is important because in hypoxia the patient will get agitation. When there is CO2 retention, the patient will get narcosis or they will get confusion. Listening for any breathing, for breathing sound, for noisy breath, example wheezes or crackles. Feeling, especially for tracheal position and for percussion, is important during examination. The treatment is that you have an open airway in order to treat the breathing, give oxygen as necessary, treat the underlying cause. Example, a pneumothorax should be drained, or a tension pneumothorax, you have to do a needle decompression. Support the breathing if inadequate. For example, if the respiratory rate decreased, call it bradypnea, or the patient is apneic at all, you have to give ventilation by mask, by bag mask. Bag mask is also called ambobac. Then coming to the circulation, the circulatory problems that you have, it might be primary or secondary. In the secondary one, blood loss is very important because in cases of trauma and even in medical like GI bleeding or vaginal bleeding, many cases may die with this blood loss. Septic shock is also important because in patients with infection, when they get sepsis, and then there will be destruction of the peripheral vessels, and there will be a lot of vasodilatation, and the patient cannot the blood will not go back to the heart, so they will having septic shock. Acute coronary syndrome, when the heart is having acute coronary syndrome, arrhythmia, hypertensive heart disease, valvular heart disease, or drugs that suppress the heart, congenital heart disease, electrolyte and acid disturbance, especially potassium, which causes arrhythmia, calcium, magnesium, which cause torsade de poids. So all of these might lead to circulatory problem. How you know that the patient is having circulatory problem? You have to look for the patient. At looking, you may see that the patient is pale. The pallor is the first sign symptom of shock. Pulse, tachycardic or bradycardic, both of them regarded as a problem in the circulation. Check the capillary refill time, it should be less than or equal to 2. Check the blood pressure. Check organ perfusion, because decreased perfusion to heart leads to chest pain. Decreased perfusion to brain leads to mental state disturbance, glaucoma will be decreased. Then decrease in the urine, decrease in the blood flow to the kidney, leading to decreased urine output. You also have to look for any bleeding, any fluid loss. Where is the bleeding in trauma? In the bleeding in trauma might be external or internal. The external is the blood that you see it by yourself. The internal, the organs that will have internal bleeding are chest, abdomen, pelvis, or long bone. This is especially in trauma. There are other causes of bleeding, example GI bleeding, whether upper or lower, vaginal bleeding. Okay, so you have to search for this and manage them appropriately. Treatment of the circulatory problem includes airway and breathing. So you have to give oxygen, support the breathing, give oxygen. Then you have insert an IV cannula. A wide bore IV cannula is needed because you need to give a fluid challenge. The fluid challenge means you are giving crystalloid. The crystalloids are ringer lactate or normal saline. Whichever available, you have to give 500 ml boluses. You have to give 500 ml bolus until you reach 1,500 or 2,000. If the patient not responding after hemodynamic monitoring, you have to give inotropes like dopamine, dobutamine, or vasopressors like noradrenaline. You have to treat the cause, stop the bleeding if there, and take blood. When you put cannula, you have to take blood sent for appropriate investigation. There are some investigations like complete blood count, blood group RH, and renal function test, serum electrolyte. You have to send these, but there are some specific reasons. For example, a patient having chest pain and you are suspecting acute coronary syndrome, you may also send for troponin. A patient is suspected to have MI, also you send for an ECG. A patient with pulmonary embolism, you send for troponin or D-dimer. So accordingly, you may send for an ABG as well. If the patient is suspected to have acute coronary syndrome, give aspirin, GTN, oxygen, morphine as appropriate. It's important to know that the larger the gauge of the cannula, the slower the rate of flow. For example, the yellow cannula is only transmitting or transfusing 20 ml per each minute. And you need to give the IV fluid rapidly. So we say it, you have to give bolus. Each bolus should be given within 5 to 10 or even 15 minutes, not more than that. It means you have to give it fastly. With a large cannula, you can ensure giving the fluid as rapid as possible. That's what call it fluid bolus. Coming to the disability. In disability, you have to check the glaucoma scale or AFPO. So these are to assess the level of consciousness. What's AFPO? The patient responds only to, the patient is alert. V only responds to voice. P responds only to pain. U unresponsive. Check the pupils for size, for reaction, for equality. Check the lateralizing sign. Ask the patient to raise his or her hands and leg. If one side is not moving, that means that it might be due to stroke or brain lesion. If the patient is unconscious, you do a painful stimulus and the patient moves one side. With the lateralizing sign, you may do also Babinski sign or plantar reflex. Do also blood sugar. In the treatment, you have to do ABCD because mostly when we talk about disability, we are talking about brain, and the brain needs good airway, needs good breathing, and needs good circulation, perfusion. Then needs good glucose. So, for example, if the patient is hypoglycemic, you have to give hypertonic glucose. For example, you may give 10% hypertonic glucose you give 50 ml boluses until the patient becomes conscious or the random blood sugar become normal. If this is not available, you can give 20 ml of 50%, give boluses until the patient becomes conscious. Consider lateral position if the patient is in coma because of risk of aspiration pneumonia. Check the drug chart because there might be a drug that is responsible for unconsciousness. For example, a patient has received opioid and become unconscious. At that time, you should give naloxone in order to regain consciousness. For exposure, the first thing you have to expose, remove the clothes, enable examination to look for injury, bleeding, and rash, and then recover the area, recover the patient to try to avoid heat loss by recovering them and also maintaining dignity of the patient. Don't forget to check the temperature in this stage, because increasing temperature might give you an idea about the patient is in sepsis. So we said primary survey is when you do ABCDE. The ABCDE is for doing resuscitation to find any life-threatening problem and you do resuscitation. The secondary survey is when you take a history and a focused examination. The history is called sample history. S stands for sinus symptom, A allergy, M stands for medication, P past medical history, L last oral intake, and E the events causing this problem. This sample history immediately follows the ABCD approach. It allows the doctor to easily communicate with the patient. It rapidly gathers history, which is critical to the management of acutely ill patient. For signs and symptoms, you may take history from the patient himself, or if the patient not talking, take history from the family or the companion. And allergies, whether the patient is allergic to any drug or not, to prevent further harm. And also the history may suggest anaphylaxis. Medications, because some medications may affect your resuscitation, the medication might be the cause of the deterioration. Also, any drug change, the dosing change. For example, a patient with epilepsy, he is having carbamazepine twice daily. Now he only taking it once daily. Then when become convulsion, you know the cause. Past medical history, this may influence the management of the patient and the drug choices and the choice of even the type of fluid. Last oral intake is important because it may be the risk of vomiting, choking, especially when the patient is having surgical procedures. Events surrounding the illness and injury, it may be helpful to know the cause and also the progression and severity of the current illness. You can know, for example, a patient deteriorated over a week is different from a patient who has sudden loss of consciousness within 30 minutes. So this will change the differential diagnosis and the rapidity of the response of you as a provider. So the summary is that if you early recognize a critical patient, you can prevent cardiac arrest. Most patients have something before cardiac arrest, a change that warns you about the patient. How is that? By airway, breathing, circulatory problems. If you detect it, you can know that what was the cause of cardiac arrest. You can use ABCD approach to recognize and treat patients which are critical, and at the same time, after ABCDE, if the patient still having problem, you go back to the ABCD. If the patient improved, then you go to the secondary survey, which is composed of history and examination. Detailed examination of the area of interest. For example, a patient supposed to have cardiac problem, you are completely examining the heart, and also you are doing ECG and troponin and echocardiography and things like that. Thank you so much. I hope you use ABCD approach to treat your critically ill patient. Thank you.